Well, thank you for joining us this morning. I think this has always been a highlight for me of the meeting to hear what our fellows have come up with. We've rehearsed with them on these, and they're, again, this year, some very exciting topics. Financial support for the presentations was provided by Nestle through the Nestle Nutrition Institute. The views are expressed here are the presenters and do not necessarily represent Nestle. The material herein is accurate as of the date, and it was presented for this educational purposes only and not intended for substitute for medical advice. Okay, so for objectives today, the first one is to discuss the indications and limitations of GLP-2 in the management of short bowel syndrome. I think you'll find this paper very enlightening when you start looking at some interesting social and financial issues of GLP-2. The second is describe the relationship between enteral nutrition, intestinal alkaline phosphatase, and bacterial endotoxin activity. Again, an area which before Caleb decided to pick this, I knew nothing about intestinal alkaline phosphatase, and now I think about it every day. I think, should I be measuring that? Yeah. So recognize the beneficial role in optimizing nutrition and exercise, promotion of healthy aging. Identify the impact of nutrition on the gut microbiome and surgical disease. Again, a very exciting area, which has been almost overloaded in this meeting with it. But I think you'll hear a new and interesting flair to this with Andrea's talk. Okay, so the four of us are the faculty for the fellowship. So all of them are up here. Ryan Hurt, okay, is on the end there. He's the new incoming president of Aspen. And then Keith Miller, just hang around long enough, you know. See, it happened to Steve too. And then Steve McClave and I'm Bob Martindale. And we're the faculty for these guys, and we kind of try to rein them in sometimes.
So Brad Solomon is assistant professor of medicine at our place, Mayo Clinic, Division of General Internal Medicine. Went to undergraduate in South Dakota State, went to medical school at the University of Nebraska. He did his internal medicine residency at Mayo Clinic in Rochester, and we were lucky enough to have him stay on staff. He is our medical director for home parental nutrition. He has expertise in EPIC and all things tech, which is very useful at our institution. Today he's going to be talking about GLP-2. Brad.
Like Ryan said, my name is Brad Solomon. I'm an internal medicine doctor at Mayo Clinic in Rochester, and again, work with the home parental nutrition team as the medical director. And with my talk today, we're going to talk about GLP-2 analog treatment for short bowel syndrome. My disclosures, again, I'm a current fellow with the Nestle Nutrition Institute for Clinical Nutrition Fellowship. I am also a co-investigator on GLP-2 studies with Zealand and VectivBio. So my objectives for my talk this morning, I'm going to take you on a journey, and we're going to go talk about a case first for the use of GLP-2 analogs. We'll review the physiology of GLP-2. We'll discuss the clinical trials of GLP-2 therapy for short bowel, and then again, I think we're going to add a little bit of a different twist to the discussion about GLP-2 by talking about some of the limitations in the United States. So let's start out with the case. So this is a patient I inherited after I started in the program, but he's a 58-year-old gentleman at the time of this presentation, and he had a history of short bowel syndrome. So he had a small bowel length of 80 centimeters with a colon continuity that was greater than 50% remaining. Again, he'd been at this time, and this was around 2014, had been on home parental nutrition for 12 years. Again, you can see his volume there, but he did infuse daily, but a smaller volume of around 1.1 liters. Again, he had been hearing about the GLP-2 treatments and had approached the team about his interest in trying that. So let's take a step back and talk about GLP-2. What is GLP-2? Well, we can see the chemical structure of it there on the slide, but it's an intestinotrophic hormone. Again, it's secreted by the enteroendocrine L cells of the intestinal epithelium. Again, these L cells are primarily located in the distal small bowel, the ileum, and the colon. Again, here's a nice slide talking about all the way from where it sits on gene 2 to the transcription and production of the proglucagon molecule, which actually houses a lot of the peptides that are then, depending upon the organ and the converting enzyme, is then further cleaved down to production of GLP-2 there. Again, when we look at the production of GLP-2, again, this is coming from the L cells, and what stimulates the L cells to secrete this is actually is food passing through the intestinal tract. So again, when it's sensing glucose, free fatty acids, and amino acids, again, that's what triggers that production of GLP-2. After it is secreted, again, it goes to its intestinal GLP-2 target cells. Again, it'll bind to the GLP-2 receptor, which then releases, as you can see, a few different mediators that go to the intestinal crypt epithelium, where that's where it's going to generate the proliferation of the villi. Histologically, we can see this. So here would be, again, a baseline intestinal biopsy, followed by, after GLP-2 treatment, 60 weeks later, you can, again, see this increase in the villi height, increase in the crypt depth, quite pronounced. From an imaging standpoint, we can see here, it can be visualized as well through a CT scan. So again, here's a baseline, then after 3 months, and then after 12 months of GLP-2 treatment. And so very easy, even for me, I'm an internist, I'm not a radiologist, but I can appreciate that. So the actual story of the kind of where the discovery of GLP-2 into understanding the biological activity, all the way into it being produced into a medication, is a fascinating story. And again, I would refer the reader, if you're interested, into this 2019 paper by Dan Drucker, who, again, if you look into the kind of history of GLP-2, he's intimately intertwined with that. And I won't go into the whole development. Needless to say, again, there was the discovery of these molecules in the 80s and 90s, as well as his recognition of remembering about a case report of a gluconeoma causing increased intestinal growth. And so through this, he was able to develop a cell line and prove that GLP-2 was the hormone that was causing this increase in the proliferation of the intestine. The other part of that slide was recognition of how the wild-type GLP-2 would be inactivated quickly, in that by altering the amino acid sequence, they were able to prolong the half-life. And again, ultimately, this led into the production of these treatments. So again, a kind of a summary slide of that affected the exogenous GLP-2 treatment. So what can it do? I would highlight the fact that this networking effect, that it can not just affect our gastrointestinal tract and all the different actions you can see there, but also, again, it goes to other organ systems. It goes to the bone. It goes to the central nervous system. And we think about it being very focused, but actually it's, again, much like a lot of the other hormone treatments, that they, again, affect multiple areas. Next, let's just dive into some of the human clinical trials. I'm just going to go over a kind of high-level overview of the results. And again, there's been multiple talks that have highlighted the results of these in a little bit more detail. But again, I think it's important just to think about the effects of this. So the first phase 3 randomized trial was done between 2004 and 2007. And that one, again, the primary outcome, this is the first one, had 3 arms. Again, it had a placebo, a 0.05, and a 0.1 dose of teglutide. In that, the primary outcome was a graded response score, and that was a table that, again, looked at how much reduction was sustained at 2 different time points. And again, they were able, in that, interestingly, the 0.1 milligram teglutide versus placebo was not statistically significant. And therefore, they did not actually, based on the study protocol, you did not review the 0.05, although in a post hoc analysis, they noted that there was a significant improvement there. But the treatment did reduce the mean parenteral support volume compared to placebo. So this led into the steps, the first steps trial and then the subsequent step series. Now we went with just the placebo versus the 0.05 dose. Here, their primary endpoint was a parenteral support volume reduction between 20 to 100% at weeks 20 and 24. And again, in this trial, that was statistically significant. Again, 63% of the patients reached that at least 20% reduction compared to the placebo. Ultimately, the 24-week, they were looking at a mean reduction in their volume of about minus 4.4. No patients in that trial were completely weaned. Again, this led into steps 2, which was the open label extension trial. This was continuing to provide teglutide to the patients. And again, here you can see again this continued downtrend in their volume requirements throughout that 2-year study period. And then the other thing also noted in the steps 2 was this recognition of we're seeing people having days off of TPN as well as achieving enteral autonomy. There were 13 patients in that ultimately were able to stop parenteral support altogether. Step 3 was another year extension trial on that where again we saw continued volume reduction. So a paper came out last month that again looked at not only the STEPS trials, but as well as some of the clinical experience of different cohort series that have been published from different centers around the world that use teglutide. They've aggregated these looking at response rates. So this table is showing you the response rates at 6 months, 1 year, and 2 years. But the message there is again is that the response rates with teglutide were improving with the longer they were exposed to the medication. Also, when we look at weaning rates, so again, liberating from parenteral support, looking at those same time points, and again, the message there was weaning rates improved with longer time. An important thing, distinction, and again, this has been certainly recognized and published about, is looking at different anatomy. Looking at the patient with an end stoma versus with a colon in continuity. The message there was, again, the response rate. So again, just looking at parenteral support volume reduction is going to be, they're going to respond lower if you have a colon in continuity versus a stoma. But when we look at weaning, you almost all the patients have a colon in continuity. So again, you're telling me all these great stuff, like, less volume, maybe some days off, wean some people, so what's the problem? Well, I live in Minnesota, it's been a long winter, I'm ready to get outside and grill, but then I was thinking about that old saying of thinking about how the sausage is made. And in the United States, I think we should be cognizant of this. So, when we look at, there was this nice paper published where they again looked at drugs that came out between 2009 and 2018, estimating how much it costs to bring a medication to market. And so teglutide was on there. And so their estimate of the authors is that to bring that medication through the pipeline costs around $1 billion. And so that is a lot of money. And again, it's a big investment in risk. Well, when you spend that much money to bring something, you got to think about what you're going to get in return. How do we recoup that investment? And so in the United States, again, we can look up with our government programs how much things cost. And so if we look at the VA Federal Supply Schedule price, you can look at the price of teglutide. And so one vial for the federal government, again, we're looking at a price of around $1,300, or for a month around $35,000. So then again, how much would a year cost? Our math would total out to be around $420,000 for that treatment. So just for comparison, again, the patient, we're usually are weaning off parenteral support, so a year of TPN, we're looking at around $100,000 to $150,000. Again, still expensive, but again, a little bit less expensive than that. So, do we have any data of how much we're actually spending? Medicare publishes how much they spend on Part D medications. And so when we look at, I put this in a tabular form, so when we look at the last 5 years, here's where we see the total spending of Medicare on teglutide was around $300 million in 2020. And again, importantly, the total beneficiaries that actually were only 847 people. And so again, the average spending per Medicare patient is around $350,000. We also have the data for Medicaid. Medicaid, you can again see the total spending there in 2020, the most recent year, was around $86 million for 2,000 claims. So that's a lot of money. And so a nice paper came out in late 2019 that from a group out of Pittsburgh that again looked at in the United States, cost effectiveness. And this is a Markov model, which is commonly used for cost-effective analysis. They looked at starting with the patient within 7 days and going as we take days away and increasing. What does that mean for us? So again, their base case is they took an adult, a 40-year-old with short bowel, the median survival of this with 12.5 years. And so without teglutide, so remaining on parenteral support, that's where you would see they estimated an average lifetime cost of $660,000 for QALYs. Again, QALYs is a way to standardize that language of 6.76. With teglutide, the lifetime cost again goes up to 1.6 million with an average effectiveness of 7.76. So that cost effectiveness ratio of QALYs, so to gain that one QALY, we're looking at around $1 million. They've done additional studies in there again and looking at again, what if we varied one of the variables? And so again, there's lots of different variables that go into that cost effectiveness. And the key message there was that really only reducing the drug cost by around 66% would actually get us down to that typical benchmark of 100,000 QALYs. This was, again, looking at multiple simulations and, again, trying to, again, say, here's that $100,000 cutoff. We still see that it became quite, in really 80% of the iterations out of 5,000 simulations, it still favored no teglutide compared to 13%. This was also highlighting that if you added in central line removal, again, you could reduce, again, when you add in complications, it reduced it, but not quite enough. So conclusions. So to prescribe or not to prescribe, that is the question. And again, it's a big question, and it's not just, about this, but it's a common question for any clinician in this country is that there are great medications, but when you're at the bedside and you're thinking about, what am I gonna prescribe this or not, there are a lot of considerations. And so I think that's helpful to when we think about what should we consider if we want to do this. Because again, we need to be thinking not only about the patient, but I think we should also think about society as a whole. And so things that I think are important to think about is their anatomy and what is our chance for enteral autonomy. I think that's one of the most important questions to justify it is can you get this patient off parenteral support altogether? If it is, again, just saying we're going to reduce the volume by 20%, that should not be the end goal and justify the cost of that. It should be really about can we get them off it together. I didn't touch base on this, but again, compliance of the patient is really important. You can give a medication, but if they don't follow short bowel diet, they don't take their medications, it doesn't, it doesn't matter what you give them. And so again, you would have to be a compliant patient to really, I think, again, achieve the most success. Duration, how long are you gonna prescribe this? Again, this is a hormone that stimulates growth. So what happens again if you take it away? What if are you going to prescribe this person this medication for the rest of their life? Or are you going to give it for a couple years as a bridge to something? So again, thinking about that I think is also really important. And then unfortunately in this country, you have to think about what insurance they have. And so again, this is where again, a lot of my thought in this case stems from is because that patient that I talked about at the start, he did end up going on teglutide and weaned off parenteral nutrition because again, he had that perfect anatomy, colon in continuity, low volume, came off, been off parenteral nutrition for 7 years, good quality of life. He now wants to change to Medicare and he cannot afford the copay. you know, it was fine and dandy when he had his commercial insurance, but going to a government payer, he can no longer afford the copay. So we're in tough discussions about what to do. So, all right, thank you.
Do you have time for a couple of questions? Do you have a couple of questions?
I got questions.
I got a couple of questions.
Wait, who's gonna go
No,
first?
you go ahead.
You go first. No, you go.
Yeah, so the social implications, I don't want to get you tied up in, because it's tremendous. You
Yeah.
know, I've thought about this a lot every time I sit at the bedside and I look at this patient who's asking me, "Doc, if I could just get one day off." I got all these short bowel patients.
Yeah.
You know, and then I go back and I think 400 grand. I'm not sure. 400
Yeah.
grand to get one day off because they have an in-stoma, which we never
Yeah.
get them. We never bridge those people to
Right.
getting off.
Yeah.
So, but my question is more the physiology. I think this is fascinating physiology and
Yeah,
how they
oh,
understand
absolutely.
this. And how it was discovered was truly the guy's a genius. To
Yeah.
think that, okay, I've got a patient with glucagonoma. Remember, this is a glucagon-like peptide. 100 amino acid proglucagon comes in the GI tract, gets cleaved a couple times, and becomes an active cell to cause growth proximally. The idea that the body is so smart that when it sees undigested nutrients in the distal ileum where the L cells are, or the
Yeah.
proximal colon,
Yeah.
it says, oh, I got amino acids and glucose here.
Yeah.
The proximal gut's not working hard enough. So to stimulate the growth back at the proximal gut.
Yeah.
So what happens when they stop the drug?
And that's something that, again, I've looked at and tried to understand more, and it's not quite as outlined as, again, the effects of while you're on it. I'm trying to remember, there was one paper, again, I think that they talked about the stimulating effect, and then you see a regression. After they, again, it returns immediately if they reintroduce it, but again, you do see that them needing more volume and stuff like that. So again, talking about you need that continued stimulation.
Yeah, I heard one, a short paper by O'Keefe, when he had endostomies, and he actually got obstruction of the ostomy.
Yeah,
Because the mucosa grows so thick
Yeah.
that you obstructed the ostomy,
Yeah.
they shut it, they quit giving it,
Right.
and it retracted back, and they were able to get affluent again. So the question was what to do with restarting. So it really
Yeah.
is trophic, but it's short active.
Yeah.
So $1,000 a day, it's
Yeah.
a lot of money.
As usual, Bob stole my question, but
I was reading it here.
Does
I
the
read it.
the trophic effect? It doesn't go back to baseline. This drug is so exciting because it changes the curve of adaptation, and we're always giving it after they've plateaued and are
Right.
fully adapted.
Right.
Should we be giving it early to change the trajectory of adaptation?
That's a really good point.
Is a question we don't know. My actual question for you, though, is this cost is prohibitive. So who gets teglutide now, and how would that change if it came off of, what do you call it, when you introduced all the other generic versions?
Patent.
Yeah, when it comes off patent.
It comes out patent in 25, right?
Yeah.
Yeah, 2025.
So who gets it now, how will that change, and who should not get teglutide ever?
Well, there again, certainly if you look at the exclusion stuff, is there are a number of patients that should not get it. Again, this is a stimulating hormone. Any cancer history, again, there's a number of different ones that at baseline shouldn't get it right now or going forward. But again, I think it's, like I said, I kind of view it as you got two groups probably. The ones that, again, you can use this to totally get them off. But also, again, the other group I would think about is more of maybe in a compassionate type situation where, again, they're having lots of, maybe they cannot, their bag is 4 liters. They need another bag. They have to infuse all day because they have such high outputs. That might be, again, justifiable for some patients, or they're, again, having IFALD. They're having other complications just due to maybe, again, they have super high macronutrient requirements. And if we can reduce that, that might help it. But again, I think we have to be very judicious and selective. And that's where, again, I think is a little different between the U.S. as opposed to a lot of other countries, is that a lot of other countries, the only prescribers can be HPN centers versus in the U.S. If you've done the REMS, you can prescribe it. And so that leads to, again, people that maybe, inappropriately prescribing this and not really recognizing some of these things versus patients that live and breathe, short bowel, treatment day in and day out. So.
I'll introduce the next speaker, who's named Caleb Kelly. Aspen prides itself on being multidisciplinary. This next speaker is a one-man, one-shop, multidisciplinary machine. He went to college at Michigan State where he got his dietetics degree. He's an RD. He then went to Tufts and did a master's in dietetics and did his dietetic internship. Then he decides to go to medical school and he enters an MD, PhD program at University of Colorado where he gets his MD and the PhD. Caleb is going to talk about the use of intestinal alkaline phosphatase as a dietetic weapon to control inflammation.
Thank you very much. I'm happy to be here and happy to be able to speak. My disclosures are that I'm a current Nestle Nutrition Fellow. And there's two goals today. The first is I'd like to introduce the concept of intestinal alkaline phosphatase as something that can detoxify endotoxin, LPS. And then second, I'd like to show you the link between nutrition and intestinal alkaline phosphatase. So I'd like to prime you with a question. What is intestinal alkaline phosphatase? A few choices. A marker of cholestatic liver injury. B, a component of the comprehensive metabolic panel. An enzyme that adds phosphate groups to proteins. Or is it a component of the gut barrier that's maintained by feeding? And I'll give you a few of the answers as we go. So this group of enzymes requires zinc and magnesium as cofactors. Comes in 4 different flavors. The one you're most familiar with is tissue nonspecific alkaline phosphatase. This is what you see on the comprehensive metabolic panel. This is what frequently indicative of a cholestatic liver injury and is expressed mostly in liver, also bone and kidney. And there are 3 other flavors, and the one I'm going to speak about today is the intestinal isoform. Turns out this is an abundant protein. This is data from 16 patients, and they took their stool samples, 3 time points each, and they did proteomic analysis on the stool samples. They identified 238 bacterial proteins and 73 human proteins. Alkaline phosphatase was the 3rd most abundant human protein. And where does it come from? What I'm showing here, it's too small to read. On the x-axis, there's 27 different tissues. So looking at different locations of the human body. It's come from 95 different patient samples. And you see there's really little expression until you get over to the colon. But predominantly expression is in the duodenum and other parts of the small intestine. And the purpose of intestinal alkaline phosphatase is it removes phosphate groups. It's very simple in its actual function. The substrates, though, are lipopolysaccharide, also known as endotoxin, bacterial flagella, and nucleotide triphosphates like ATP, among others. And as a way of reminder, this is a highlight of certain components of a gram-negative bacteria. Zooming in on the cell wall, instead of the one membrane that we have, they actually have 2 cell wall layers. And the outer layer of the gram-negative bacteria is composed primarily of this protein called LPS lipopolysaccharide. Zooming in on that molecule, you see that also has some complexity. And there's this moiety called the lipid A region. There's no way you'll see this, but there's 2 little phosphate groups on that lipid A moiety, and it turns out they're important. Okay, another cartoon, and I'm showing you, again, the LPS here. It's one of the most potent inflammatory mediator or stimuli for the human body. And when it's encountered, the human body detects it through LPS binding protein and CD14. When those interact with the lipid A moiety, it then binds the toll-like receptor 4. That's how our cells are able to detect this inflammatory signal. That then causes intercellular signaling cascades that ultimately result in different forms of inflammation depending on the cell type. Now, intestinal alkaline phosphatase is the one that's pictured in green there. Green up at the top is intestinal alkaline phosphatase. And again, it just takes off that one little phosphate group and it turns diphosphorylipids A into monophosphorylipids A, and that's enough to make it so that it doesn't bind the CD14 and LPS binding protein, and there's no inflammatory signal that's generated by monophospholipid A. We can actually visualize this. So what's shown here is human intestinal epithelial cells under the microscope. I'll point you to the top rows first, and several things are stained. The first is one of the subunits of NF-kappa B. NF-kappa B is one of the most common transcription factors that mediates a number of inflammatory genes. It normally resides in the cytoplasm, and that's where you see it. The nucleus is labeled in blue, and you can see when they're merged that the blue and the red are separate. When the cells are stimulated with LPS, all of the NF-kappa B goes right into the nucleus where it has a pro-inflammatory effect. When the cells are co-express intestinal alkaline phosphatase, the NF-kappa B doesn't go anywhere. There's no effect. The pro-inflammatory consequence of LPS is negated. Now here's where you may find it interesting. Intestinal alkaline phosphatase is maintained by feeding. This is animal data, and it's a number of different mouse groups. They were all sacrificed at the same time. And I'll orient you first to the bar in white. Those are just the control group. When the animals were fasted for 48 hours, the expression of intestinal alkaline phosphatase and alkaline phosphatase activity, as is shown in this graph, is decreased. When animals were then refed after fasting, it was restored. When the same experiment is done in intestinal alkaline phosphatase knockout animals, there is no response to feeding. So this has been looked at in several ways. This is an example of a TPN model looking at a similar type of experiment. And it turns out you can put mice on TPN. You need a skilled technician who can insert a catheter, and they run around in a little harness in the cage. And so these mice were on TPN for up to 4 or 5 days. First, I'll point you to the control group, the chow, which is on the left, and compare it to the group, the bar on the far right. That's the TPN group, much lower expression. Now, all the animals had isocaloric, isonitrogenous feed, and when 10% of the nutrition was given as enteral, there was some increase in the alkaline phosphatase. And when 20, 40, 60%, there was more restoration. That translates to an improvement in barrier function. And this is a type of assay where the animals were gavaged with a fluorescent marker. And normally the gut barrier will prevent that from moving across. But when the barrier is disrupted, it can then go across into the bloodstream. And when the blood is sampled, the fluorescence can be measured. So for reference, on the left is the group that is receiving normal feed. The group to the right hasn't had food for 48 hours, and the intestinal barrier is impaired. And that was recovered with the exogenous administration of intestinal alkaline phosphatase. And you could take it a step further and think about bacterial translocation. This is an interesting model. It uses distal injury, a hind limb ischemia reperfusion injury. So essentially they put a rubber band on the hind limb for several hours, causes injury to the limb, and then they look 24 hours later and see what type of bacteria and how many bacteria are able to cross the barrier. And they dissect the mesenteric lymph node and culture the bacteria out of the lymph node. That's what's shown in this figure. So with the sham procedure, there's no difference. But with the actual injury, animals that don't have intestinal alkaline phosphatase have much more bacteria that translocate across the gut compared with control animals. So does this have any relevance for humans? Possibly. This is about the best data we have. I showed you earlier how intestinal alkaline phosphatase is largely expressed in the small intestine. In the colon, there is alkaline phosphatase activity, but it's a combination of intestinal and this tissue nonspecific, which can be associated with inflammation. So the best way to really look at this is to look at ileal samples or small bowel samples. And surgeons came up with a great way to do this. They had patients that had new ostomies that were created, and they collected the fluid from the ostomy shortly after it was created. The patients were still NPO from the procedure, and then they subsequently resumed their nutrition, and then they collected samples from the same patients after they had started eating. And you can see the enzyme activity of intestinal alkaline phosphatase is much higher after feeding. And this is the only study I'm aware of in humans that has used exogenous alkaline phosphatase to try to look for an effect. Many limitations here. This is an uncontrolled trial. The setting is patients with ulcerative colitis. There are 21 of them. And they give a modest dose via an intraduodenal catheter, and that was given over 7 days. Possibly they saw some response, but I don't make too much of that small uncontrolled trial. This is hypothesis generated, but really it demonstrates that it may be safe and it was well tolerated. So in addition to nutrition being a way to maintain expression of intestinal alkaline phosphatase, possibly there could be a role for developing it as exogenous treatment. So to summarize what I've told you, when animals, or presumably humans, are fed, those nutrients maintain the expression of the intestinal alkaline phosphatase, which is both a membrane-bound and secreted enzyme. That acts on various substrates, including LPS, to remove a phosphate group, and just that simple step makes LPS no longer immunogenic. It no longer interacts with the toll-like receptors. I've only showed you a few things. There are other studies out there that look in other contexts, models of salmonella infection, C. difficile, chronic alcohol, experimental colitis, metabolic syndrome, and age-related dysbiosis. So the bottom line, take-home message, as a physician, I'm not going to change my practice, but I do think about alkaline phosphatase differently. It's not just a marker of cholestatic liver injury. There are other isoforms, and there's a biologic role and function for this enzyme. As a scientist, a lot of questions. One is, what are the macronutrients that are important for stimulating this? Or is it just a matter of stimulating intestinal blood flow? Some is known, but it's incompletely understood. What's the role of micronutrients? Again, some is known. Possibly vitamin D has a role here, but a lot to learn. And are there inhibitory dietary components? There's an intriguing study that showed that aspartame can inhibit intestinal alkaline phosphatase. They did an in vitro assay where they incubated regular soda and diet soda with the enzyme, and they found that the diet soda inhibited the enzyme activity. It turned out it was the phenylalanine from the aspartame, and they went on in animal studies to show that it can inhibit. But is that relevant for humans? It's unclear. And finally, as a dietitian, I really like this idea. It provides a clear link between what we do when we prescribe nutrition and how we're helping to maintain the gut mucosal barrier. So with that, I'm happy to take questions.
Any questions in the audience? We have microphones there. Please feel free to go up and ask your questions. Maybe while we're waiting for someone to come up, I have a quick question. Okay, so we have the new 2021 guidelines, which I wasn't part of and Steve wasn't part of, and disclaimer. Okay, so it says enteral is equal to parenteral. But I see this, and after 30 years of study, loving the GI tract, I see here's more data that says when we feed somebody, if you look at that TPN, there's no intestinal alkaline phosphatase. We know there's enough LPS in our GI tract right now to kill every one of us, right?
True.
If we took it out and we isolated it and took it back as intravenous, we could kill each other. You could kill everybody in the room with what's in our LPS. So that's what's keeping us from dying. That sort of thing, protecting that brush border. But yet they say enteral is equal to parenteral. I don't get it.
Yeah. Bob? I love the GI tract even more, Bob. My question is, these refined formulas don't get too far down in the GI tract. Is that a problem? Because this major effect is at the distal small bowel. Do we need to change that paradigm in any way?
That's a great question. And I wonder if some of that's reflected in the animal study on parenteral nutrition, where you had some effect with 10% of calories enteral, and you had to get up to higher fraction of enteral feeding. I don't know if that's reflecting that providing that additional enteral nutrition was stimulating further down the small intestine, possibly, but it's a great thought.
Let's go to the audience.
Quick questions. Is there a correlation between intestinal alk phos and serum alk phos?
It can be, if you fractionate a serum alk phos, part of that is intestinal alkaline phosphatase, so it's included in that. But usually what's measured predominantly in the serum alkaline phosphatase is the tissue nonspecific. And I don't think that measuring a serum, unless you're measuring the intestinal fraction, would necessarily reflect what's happening in the small intestine.
Right, okay. And did you look at parathyroid hormone and vitamin D in relation to alk phos? The feedback mechanism for bone profiles?
Sorry, I didn't quite catch that.
So did you also look at parathyroid hormone and vitamin D in terms of the feedback mechanism with alk phos?
Great. There is information with vitamin D. Is something that can, at least in deficient animals, restoring vitamin D would increase the intestinal alkaline phosphatase. So yeah, that probably is involved in this, as well as phosphate and calcium homeostasis.
Thank you so much.
Hey, thank you for the great talk. I just have a question. So the alkaline phosphatase pathway and the response to TLR4 is partly a protective mechanism too. So by giving an actual exogenous alkaline phosphatase, isn't there a concern that potentially you could cause, in an extreme case, sepsis or similar, because that pathway is kind of preventing from infiltration in the end, kind of?
Yeah, that's a really interesting question. So that essentially the immune system may not be able to sense the bacteria, potentially pathogenic bacteria that are there. That's really interesting. So far, it's only been looked at in a couple models with C. diff and Salmonella, and it didn't seem to be the case in those models, but those are animal experiments, just a couple pathogens. It's an open question. It's really interesting.
Thank you.
You mentioned, I presume the majority of that is coming from the liver. Can it do everything the intestinal alkaline phosphatase can do, or do we lose some of the benefits from the intestinal version?
That's a good question. So you're wondering, will it dephosphorylate LPS equally as intestinal?
Yeah, and be equally protective.
I'm inclined to say the answer is yes, but I actually don't have, I'm guessing there. I actually don't know.
I think it still can maintain the circulating effect on detoxifying LPS, but I think we lose some of the defense protection at the level of the gut.
And I would expect that because the liver nonspecific alk phos is expressed largely in the biliary epithelium. That's a site where that's susceptible to infection, and I would expect that may be there to protect from inflammation from commensals. So I think the answer is yes, but
it's not as good as the real deal, the intestinal version.
So Dr. Haynes, it is my honor to present or to introduce her. She is a fellow trauma surgeon. Trauma surgeons across the country like to think of themselves as Swiss Army knives, that they can deal with most of the things that roll through the doors. She is a Swiss Army knife with a few features that most of us don't have. She's truly an all-star. She is an intensivist. She's a surgeon. She's a medical ethicist. She's a researcher with a K Award. and I'm told a perfect score on her K Award. I love that. But she is an assistant professor at Duke in trauma critical care surgery. She did her undergrad at USF, her DO at Lake Erie College of Osteopathic Medicine. She's been all over the country. She did her internship at UNLV. She did her surgical residency in Des Moines. She did her trauma critical care fellowship in Madison and is now at Duke University, and we are just thrilled that she's going to be talking to us this morning about optimizing nutrition in older adults. So, Dr. Krista Haynes.
Hi guys, thank you so much. That's pretty kind. So, besides being a Nestle Nutrition Fellow, which has been amazing, by the way, I also have funding from a bunch of organizations, the NIH, so these are all of my, as Paul Wishmeyer likes to call them, alignments of interest instead of disclosures. So I want to talk about aging, and these are the objectives. Then I'll tell you a little bit about myself and why nutrition matters to me so much and what I do. But we're going to try to look at the importance of health benefits in older adults, understand the impact of why exercise matters, because no matter how much you guys do and we do to provide good nutrition to older adults, if we can't get them to move, it's not going to work. And then finally discuss some of the measures and ways you can test outcomes and see what we're doing in both clinics or clinical interventions. So let me tell you a story about one of my patients, and this is the reason I think nutrition is so important. This is the beginning of COVID, no visitors allowed in the hospital to lay the groundwork. I get a call from my intern who's terrified. We have a 74-year-old man in the medical ICU who's on rocket fuel, 3 pressors, has belly pain. Nobody knows what's going on. His blood pressure is 50 over 30. They're pushing epi, and they say, "Surgery, can you please help?" So we all run over to see this patient as fast as we can, look at his belly, call anesthesia. We're pushing pressors. We take him down to the operating room because otherwise he's not going to live for the next 10 minutes. Get in there, and not only does he have one of the largest holes in his duodenum I've ever seen, but his entire colon is dead. Shockingly, a few hours later, we get him through that operation. We take him back to the surgical ICU. We leave him open for a day. We take him back. We get him closed. Great success. Tons of drains. There's no way to close that duodenum. We put some momentum on top of it and put him on TPN. This was a golfer. He was out with his family all the time. He happened to be in the hospital for 3 days before this. He was active in the community. Amazing man, amazing family. Still in the hospital 64 days later, which for me as a surgeon, hey, that's an amazing outcome. But he's got still bile leaking out of his duodenal drains. I keep putting him on TPN. Am I allowed to say the word SMOF in here? I keep putting him on SMOF. His LFTs go up every time I leave service. He goes off SMOF. No matter what my RDs do, they stop his nutrition. And we starve him for 64 days. We keep trying to do enteral nutrition. It's not working. He can't tolerate it. His drains start pouring out. He gets distended. And he lays there. His wife can't come visit him. They're best friends. None of his family can come visit him. And it's just us trying to keep this guy motivated in the hospital. But now he's so weak, he can't stand up, he can't do anything. And so I get called on a Saturday by one of my partners because I was off. And Sean told me, he's like, "Do you want to come in? We need to talk," because he's done. And he literally, I walk in the room, his whole family shows up, we allow him in the hospital. It's the first time he got to see his wife, except on a video camera in months. And he just told us he was tired of being alone. He never thought he was going to get stronger. He says he's weak and he didn't want to live anymore. So with that in mind, with the family at the bedside, we started some pain meds and transitioned him to comfort care. So this should have been a surgical win, and it could have been a nutritional win, but because of lack of education and the ability for us to, and I mean, we have the best nutritionists ever. I mean, you probably do too, but I mean, I love mine, Laura. But without being able to feed this guy, no matter how good of a surgeon I am, I can't win. So that's why surgery and nutrition are important to me, and I study older adults. So back to the talk, sorry. We're going to look at the importance of health benefits and nutrition in older adults, understand, as I said, the impact of nutrition on exercise and nutrition-related outcomes, and discuss the measures to impact these. Malnutrition starts, honestly, when people are 40s and 50s. By the age of 70, their lean body mass and total body weight has decreased significantly. They have increased sarcopenia, which leads to increased osteoporosis. They fall, fractures. This decreases their overall quality of life as well as any type of outcomes. They also have malnutrition associated with their cognitive function and impaired physical function. So their activities of daily living, dressing themselves, brushing their hairs, their instrumental activities of daily living, these are all impacted by their nutrition, and they also cause malnutrition in older adults. I stole this slide from Bob, but I love how nutritional states of older adults and all the things that impact them and what's going on. So as we said, the physiological changes of aging that we're trying to stop, medical diseases, medications, activity level. There's some genetic components to it that we've talked about, and then definitely socioeconomic status, which there's not a lot of in the literature for, but there should be. When we're looking at these patients, not only do they have worsening physical performance, so they can't prepare their foods, their swallowing hurts, they don't want to eat, their taste goes, their vision goes, so the food no longer looks palatable. But also we have polypharmacy on all of our older adults. So they have tons of drugs they're taking, not that they want to take that many pills, unfortunately, and the drugs have an impact on their appetite. So even if they're trying to eat and trying to listen to us, it's very hard on them, and we get what we call the anorexia of aging. So what does nutrition do for these people? For diet actually impacts cognition, and I'm going to show you a bunch of articles next that show where it not only prevents dementia, but also improves healthy aging. But we have DHA, which we know improves neuronal signaling. We know that DHA improves brain energy. The brain consumes 20% of the oxygen in the body and only makes up 2% of the body weight. So we need a lot to keep that brain working. And then energy in general, besides the drugs having effects on appetite, it also makes them weaker and tired. Here's just a couple of the studies, and I didn't put these up so you could read them closely, but here you can see that ketogenic diets have shown promise in treating the progression of dementia as well as aging. So the impact that you guys have on people and that we can have on getting people better and sending them home and getting them out of the hospital is massive. This is an article showing how many areas of the body are impacted by nutrition when it comes to aging-associated diseases. So frailty and sarcopenia, as we've talked about, osteoporosis, but even things like hearing loss is impacted by nutrition. Cancer, obviously, obstructive sleep apnea, more on the obese side, but those people are still malnourished about 50% of the time. And urinary incontinence, constipation, anything that would impact their quality of life, not get them out of the house. So here, great study, personalized nutrition for dementia. So we can impact all areas of a patient, including what they're exposed to, what kind of outcomes they're going to have just by altering their diet. Looking into fish oils, omega-3s, and supplements, this is an amazing study on Alzheimer's disease that shows if we're giving these supplements, look at the overall improvement in every category on a meta-analysis. So back to my point that no matter how good we do feeding these people or getting them to eat or encouraging them to eat, that without doing it, we are still having anabolic resistance and aging, and the only way to deal with that is to add some type of physical function and exercise. So here you can see that despite aging is not the worst thing that can happen to you, we can overcome it. Sitting down on the couch, obviously, and being obese are going to cause you much more anabolic resistance than aging. But these are things we can actually impact and I think are important. So here's another article about the importance of sarcopenia and aging. So nutrition alone, as I keep saying, is not enough. We need to get these people protein, and I'll talk about in a few minutes how we need to spread that protein out. But 1.6 to 1.8 kilograms per day is the recommendation of this article. 3 main meals, and we're going to tell you that should probably be even more. Resistance and exercise training at least weekly, and reduce their sedentary time. just to kind of hone this in, this is the summary of protein challenges for the elderly. So not only do we need to do high quality protein, but we need large studies to show this works and see how we're going to actually impact those and look at some actual good outcomes. A lot of the older studies, besides some of the amazing ones on brain and dementia, look at mortality as an outcome when we should be looking at how all these people function. And I'm going to go through some of those functional studies. And then physical therapy, and our physical therapists should be partnered with us and our dietitians to be able to get these people out, because otherwise, no matter how much hard we work, it's not going to work. Here's the Protein All Day program that came out in 2013, and to be honest, I had not heard of this until a couple months ago, and we keep talking about it amongst our older population, trying to get them to do some type of a protein drink at night. But it's shown that nighttime protein supplements and then having protein distributed out the day absorbs it better. So breakfast, lunch, dinner, and then a snack. Here's another example of that, but talking about the nighttime protein supplements, you can see here in elderly males, if they have a nighttime protein bolus, their absorption and their increase in protein has improved. So adding to that, the importance of physical exercise on our muscle mass and sarcopenia. So looking at the impact of nutrition when we're giving them, this group, they looked at a group without supplements, and then they gave some people whey protein, fish oil, and vitamin D. And then not only did they do that, but they did some exercise training. So they did muscle-related indicators as their outcomes, as we keep talking about, that are important, including grip strength and compared to a pre and post intervention. And as you can see, nutrition, supplementation improved muscle mass, as we would assume. And aerobic resistance training improved muscle mass and sarcopenia. And combining the two does an even better job. This is kind of a long list, and there's a lot of websites out there where you can click on these. This is the one we have at the Aging Center at Duke. You can click on any of these to figure out how to do them in your office. They're pretty easy, but these are functional measures to see if we're actually accomplishing our goals. So you meet a patient and you do a grip strength or you do a quad strength. We have a lot of other fancy things we love, BIA, muscle sound. And you measure these at the beginning of your time treating them or preoperatively. I never get to get anybody ready for surgery. They just show up malnourished and then we have to fix it. But as soon as they get there, we try to get some type of functional status from them. Say they fell or they were in a car accident, we at least can get a baseline to know where we're going. And then try to do our interventions, our ICU physical therapists work with them, start doing moving exercises as soon as we can. We're starting programs where we are trying to do targeted nutrition. All of those are research at the moment, but hopefully they can start being full practice because we can prove that we need more funding for all of our RDs to be there. And then at the end, you can do these, including the PROMIS scores, and find out that they have better quality of life, better functional outcomes. And I think if we start using these measures to do our studies, then we're going to have much more robust data and proof that we're actually improving lives and not just improving numbers. I don't think people care if they're in a hospital for 1 day longer or 1 day shorter and we fixed length of stay. I know it helps money, but it doesn't really help people. Here's an example of just one of the ones that's in there that I use all the time that's called the Senior Fit Test, and it's a 6-item protocol. I use it on my older adults. I have an NIA grant where I try to work with older adult trauma patients and see how they do over a year. And I try to do as much of this as I can in the beginning. Obviously, it's hard to get them to sit and stand from a chair when they just got in a trauma. Most of them have rib fractures, though, and their legs work. But then trying to follow them up, give them nutrition, see how they do later, and then get these functional statuses as well as their quality of life. The other thing that we measure during this time is their activities of daily living and their dementia, so their ADLs and their IADLs, to make sure that we keep them functioning, keep them brushing their hair, keeping them getting dressed, keeping them cooking, so that they do better. So, in conclusion, quality of life and independence is one of the most important things to my favorite patient population, which is the older adults. Data shows that despite giving them a healthy diet, getting them to eat it, if we don't get them to do some kind of movement, it's not going to work. So there's got to be a way, even if you're not doing research, to create a healthy diet and exercise program for all your patients.
Krista, I've got a kind of an important talk. This talk hits close to home. The question is, how do we reach the target audience? Do we have to wait till a health issue brings them into healthcare providers? Are PCPs educated and qualified to give some of this guidance? And then the second thing is when do we intervene? Do Bob and I need to sign up for this afternoon?
Yes. No, months ago.
Too late for you.
Yeah.
So we've created a bunch of clinics for patients that we can get to. We have a POSH clinic where we bring people in and do exercise, diet, nutrition programs for them. We give them a couple weeks of nutrition. We give them exercise before we'll do a surgery on them. But to be honest, not everybody interacts with the healthcare system. Most of my trauma patients never interact with the healthcare system until we see them because they fell. They don't want to be there. So that's our one time to interact with them then. But if there's a way to get out into the community and start talking about nutrition and getting people to understand what protein is versus the calories, it's amazing when I just go sit with my patients and I'm like, are you eating your protein? And they're like, yes, I have my bread. So just getting out there and getting community educated and getting these people moving, I think, is important.
Okay, any questions from the audience? Okay, you know, I don't see anybody. Just, okay, yeah, go ahead.
Hi. I'm just curious, you talked about the quality of protein. What do you define as quality protein?
Anything I can get that in them that they'll eat. I mean, if we're doing actual studies, yeah, we have better protein supplements, but I mean, just trying to get them food that they can actually eat and afford is better than where we are now.
Good morning. I do trauma critical care myself, and one of the things we have to have in our Swiss Army knife, it would seem, is the little attachment that says geriatrician. You know, one of the patient populations that I'm sure we all see quite a lot is the patients who fall and have hip fractures, which we have a role in taking care of. So what I'm wondering is, since there's a significant incidence of malnutrition in those patients, what are some tips you can give to enlist dietary and your sort of support to get them up, to get them protein? I am of the school that, you know, a good protein intake is very helpful for them.
Yeah.
So if some of the tips you can get to sort of get things going for them in terms of integrating protein and physical therapy and everything, that'd be great.
Yeah, so we actually agree with you 100% and try to start protein and nutrition supplements on day one and encourage that for all of our trauma patients. But I'm sure many of you know we published a recent study that showed that with patients with hip fractures, most of them don't get any oral nutrition supplements for at least 3 to 6 days, despite the fact that it improves length of stay and actually saves the hospital tons of money.
She's been waiting longer than I have.
So I do have a question with regards to taste alteration. As we know, as we get older, we lose our sense of taste. How do we combat that? Because they may have a desire to eat, but if they don't like the meat, they're not going to eat meat.
I wish I had a good answer for you. I don't know if anybody else has a good answer for this one. I walk in the room every morning and I say, what flavor do you like of shakes and what can I bring you? And I look at their food, and I know I'm a surgeon, so everybody looks at me like I'm crazy when I'm doing this, but and I encourage my nurses to get them anything that they will eat. But long term, I don't think we have any.
Good morning. I appreciate your talk. Thank you very much. In the intensive care unit, what I see a lot is intubated, sedated from our rehab specialists. And, you know, question for you or any of the panel members, are you able to impact that at all? Do you, leave that as it is, intubated, sedated? That could be a very long time that happens. And then when the edema is gone, what we see is just muscle and fat wasting.
So you're asking if I should exercise my patients while they're intubated and sedated, or when I start nutrition?
About exercise.
Yeah. So we have some passive equipment that we can do that stimulates thigh muscles. The data on that isn't amazing. We are working on it, but we do try to start nutrition as early as possible in all of those patients, enteral or IV. We have some patients, if, for example, you get shot in the pancreas, your gut's not going to work for a very long time. So I'll start nutrition on them within 48 hours as long as they're resuscitated, meaning IV.
Thank you for the talk. I just have a question in regards of the digestion efficiency in age, because there's so much research out there that basically tanks down the older you get. So is that considered in the supplement area you're providing? Are you giving a broad spectrum of different enzymes to help the patients to actually digest it, not only intake it, but be able to use it?
So you're asking if with the supplements, if with the protein supplements, we're giving other types like vitamins and mineral supplements?
No. Are you, for example, when you're giving protein, are you also providing proteases? Because they have been shown to go down with age as well. Yeah. So you can give as much protein as you want. If the patient can't break it down, he's not going to absorb it.
Yeah, yeah. As of right now, we are not, but that's, perfectly great point.
Okay, thank you.
Thank you.
It gives me pleasure to introduce Andrea Stroud, who is now one of our faculty members at my institution. It's been a pleasure to work with her over the last couple of years. She's from Madison, Wisconsin, where she was born. She went to Hamilton College, went on to NYU Medical School in New York, then went to the peaceful Dartmouth residency, and then back to Wisconsin for an MIS fellowship. And we were very pleased to get her out of there and to get her out of, I mean, Madison's a great place, but Portland used to be nice anyway before last year. Anyway, and then got her in Portland. So she's been a great contribution to our bariatric service and is doing lots of work in that area. And she's become quite a researcher with Dr. Bruce Wolf, who runs the Longitudinal Assessment of Bariatric Surgery program, which is a 20-year program on bariatric surgery. And she'll show us some data today from that. It's very exciting.
So it's a little different than the program initially suggested. I changed my talk a little to fit in the time, but my research interest is the overlap between obesity and cancer and how bariatric surgery might affect that. And I'll touch a little bit on the microbiome at the end. Disclosure is that I'm a nutrition fellow, and these are my objectives for you today. So we'll start here. So we are all familiar with these images of the United States and the obesity epidemic and how we're getting an increasing number of this dark red color. But what some people might not know is that severe obesity, which is the group of people that I take care of in my clinical practice, is the most rapidly increasing group and is expected to represent 1 in 4 Americans within this decade. And we only reach about 1% of eligible patients with bariatric surgery at the current time. So this is a landmark study that was published in 2003, the Cancer Prevention II study. And what the authors concluded is that the individuals with the highest BMI, so those with a BMI over 40, are at a 50 to 60% increased risk of dying from cancer. So you can see both for men and women at different anatomic sites, it's anywhere from 1.5 to 6-fold increased risk of dying. And there's been numerous epidemiologic studies linking elevated body mass index with both cancer risk and cancer death. In fact, the International Agency for Research on Cancer convened a working group. They reviewed the evidence and found that there was 14 different cancers that can be consistently linked with obesity. And these obesity-linked cancers now represent over a quarter of the global cancer burden. This is data from a meta-analysis showing the different anatomic sites that are affected. And what you might notice is that there's a large number of GI tract cancers and endocrine or reproductive organ cancers in this obesity relationship. So if obesity can increase your cancer risk, what happens with weight loss? And there is epidemiologic evidence from the breast cancer literature that even modest weight loss can decrease your risk of getting cancer. So we do think weight and weight loss is important. And now there's been some increasing evidence from bariatric surgery cohorts across the world that bariatric surgery and the weight loss that you get might actually affect cancer risk. So hopefully this will be new to some people. The Swedish obese subject study is the longest, largest study we have in bariatric surgery, obviously conducted in Sweden, so it's a homogeneous patient population, but they do have the advantage of a nationalized health system, so they have very good follow-up of this cohort. It was over 4,000 patients with obesity. 2,000 of the patients elected to undergo bariatric surgery, so it's not randomized, it's a cohort, and 2,000 are a matched control group, and they've followed these patients over the years. And what you see is around 10 to 15 years after surgery, the mortality curves start to diverge pretty dramatically. And individuals that have had bariatric surgery have a mortality advantage, whereby at 16 years of follow-up here, they had a 40% reduced risk of dying. And one thing that came out of this study that was very interesting was that a reduced cancer death rate in women was a very important contributor to this mortality benefit. And it wasn't even a predefined endpoint. They weren't even thinking about it. So it was kind of an interesting finding. And what you also might notice is that it was not present in men. This is a little bit of a complicated issue because most of the patients that get bariatric surgery are women. In my clinical practice, I looked back for the last 4 years, and it's 80–90% women that are getting the surgery. So we're not taking care of as many men, so that might contribute. And in this table, I've summarized the 3 studies that I think are the most important for understanding what we think is going on. So the Swedish study is the first graphic, and then in Utah, some surgeons followed a group of patients that had Roux-en-Y gastric bypass. And then Kaiser, I think we're all familiar with Kaiser Health System, and this was done in the Western United States, and they had over 90,000 patients. And I think what's important to take away from this slide is different cohorts, different methodologies, different patient populations, I got a remarkably similar result, which is that having bariatric surgery compared to staying obese reduces your risk of cancer by 30%. So just to soak that in, like that's a very big effect size for any sort of intervention or medication. This is just to show that all of the cancers they looked at favor bariatric surgery and that there's a pretty good overlap with those obesity-associated cancers that we showed earlier. So I was fortunate, as Dr. Martindale said, to be involved with the labs cohort. And this cohort was actually conducted in the early 2000s, 2006 to 2009, at 10 different sites across the US, and over 2,400 patients participated. They're having a primary bariatric operation, and they're followed annually. They fill out health forms that are really comprehensive, including a specific form asking them about cancer, and they also contributed biologic samples at every visit as long as they were able to give blood. So what we did is we looked at cancer incidence in this group over the long-term follow-up, and after our exclusion criteria, which included anyone who developed cancer within the first 12 months was excluded because we would consider that a pre-existing cancer. The majority had Roux-en-Y gastric bypass, but we also have a good population of gastric bands, which is, as many of you might know, kind of an outdated procedure at this point in time. But it is kind of a nice representation of weight loss through restriction rather than some type of anatomical change to the GI tract. And our patient population is typical of a bariatric patient population. They have a BMI in the 40 to 50 range. They are majority female. And we have a good number that used to smoke, an important risk factor for cancer, obviously. And also half had diabetes. This is the weight loss that was previously published for the lab study over the 7-year follow-up. And what you should take away from this slide is that if you get a gastric bypass, you tend to lose a little bit more weight. So that's total body weight loss in blue for the gastric bypass and in gold for the gastric band group. And this was sort of the main finding of our study, which is that showing here a survival analysis, follow-up over months of patients based on how much weight they lost. That's what those categories are. So if you lost less than 20% of your body weight, you had a much greater chance of developing a cancer. Whereas the people that lost more in the typical weight loss category, so the average patient is going to lose like 25 to 30% of their body weight, then you have a reduced risk of cancer. So we do think weight loss is probably playing an important role in this relationship. We also looked at metabolic markers, and if you had improvement in your diabetes and your adipokines, that was also associated with a decreased cancer risk. So probably something to do with the metabolic changes after surgery also plays a role. So just going to the mechanism side, I'm probably not as good at this as Caleb, but adipose tissue turns out to be an important endocrine organ. I didn't ever learn about it in medical school, but it makes hormones, it sends out inflammatory signals, and it makes these hormones adiponectin and leptin. And then one other thing that I think is increasingly recognized is the role of the gut microbiome in this relationship. So in this image, what it's showing is that the adipose tissue mass hypertrophies with obesity. So you get expansion of the adipose tissue through hypertrophy of individual cells and increase in number of cells. And these cells then are making more insulin-like growth factor, IL-6, which is an inflammatory cytokine, and these adipokines that I mentioned. And what you see is that they are signaling molecules for receptors that set off intracellular signaling cascades that promote cancer mechanisms such as cell cycle progression, survival, angiogenesis. And then estrogen, we mentioned that the effect has primarily been seen in women, so estrogen has been implicated strongly. Estrogen is obviously a well-known risk factor for breast cancer and has numerous cancer-promoting effects that are demonstrated in this slide here. But why it's important is the adipose tissue is the primary site of making estrogen outside of your ovaries. And once you have menopause, it's the site for it. So if you have expanded adipose tissue, you have more estrogens in your system because aromatase, the enzyme that is the final pathway to the estrogens, is upregulated and exists in the adipose tissue. So women with obesity have higher levels of estrogen, particularly estradiol, which is one of the most potent estrogens, and the sex hormone binding globulin that carries the estrogen in your blood is decreased, so the bioavailability is increased as well. And then microbiome, I'm sure we've all been hearing a lot about this more, and dysbiosis has been linked with both obesity and cancer. And interestingly, even though it's relatively young science, bariatric surgery actually is shown to shift back towards a healthier microbiome. So I think that this is probably going to be something that we're going to hear more about in the future. And a specific microbiome signature is being associated with multiple different types of cancers, and notably these are all cancers that are elevated in obesity. So I think it's definitely has potential both as a screening or preventative strategy as well as maybe therapeutic in the future. So basically, I think what I'd like you to take away from today is that obesity is probably one of the more important risk factors for cancer. It's preventable. It's poised to overtake smoking as the most common preventable risk factors for cancer, and that bariatric surgery is probably an important tool and model to better understand this relationship. Thanks.
Any questions for Andrea, please come up while we're waiting if anybody has a question. So, I know we've sort of joked at OHSU because we have such a big presence for our obesity program with Dr. Wolf. When the pancreatic surgeons present their data and they talk about all the surgeries they do and they save here and there. So Dr. Wolf very appropriately said, it looks like if we calculate the numbers, we're saving more lives by doing bariatric surgery than you're saving by doing pancreatic cancer surgery. And if you look at the numbers, what do you figure? What's the 5-year survival for somebody with a stage 1 or stage 2 pancreatic cancer? 5 to 15%, right? If you do the same amount of surgery on bariatrics, you're going to save about 11 to 12%. So it's an interesting thought that we spend a lot of time and energy. Maybe we should just be focused. Now, I'm a recovered bariatric surgeon, as you know. It's like alcoholic. I don't do it anymore. I'm on the wagon. But I sometimes wonder, are we really missing the boat? I mean, everybody goes, oh, that's their own fault, it's self-inflicted disease, it's not like pancreatic cancer. But really, I think sometimes we miss it. So what's your philosophy for the future of bariatric surgery? It'd be nice to have a drug, but is the answer going to be just more surgery, train more bariatric surgeons?
Well, in an ideal world, same with Brad's talk about medical spending and ethics behind all of this. Like, we should be trying to prevent obesity so that I don't have to be doing this, but I don't see any end in sight. Our wait list is over a year at this point, and so the future is that I have job security, but I would like us to put me out of business by trying to prevent this disease by promoting the idea that the current Western diet is killing us. Like, come on, why are we eating the way we do? I'm happy to see the breakfast that was served today because you don't always see that at medical conferences. So anyways, that's my opinion. Prevention, not surgery.
Yeah. Okay, well,
I've got a question.
Hold on, Bob. Okay, go ahead, ask the question.
So one of the areas I think about is who's at high risk for cancer, right? So I think one of the pivots, because obesity, there's a lot of heterogeneity in obesity. I think of your wait list of patients, and if you're trying to really make an impact on cancer, I would start thinking about, how do we identify, how do we screen patients? We're obviously doing some things at Mayo with genetic screening about who's at higher risk for some of these things, pancreatic cancer, et cetera. I think that's the target that I would think about as far as bariatric surgery. We often take care of patients, bariatric surgery's gone wrong in the nutrition world.
Sorry.
And so I that's all right. But so I think about, how do you impact patients the most? And I would look at who, before you operate, is at higher risk for developing these sort of issues.
Yeah, and I think, there's some trends to decrease the age at which people are getting screened for colon cancer and maybe for breast. It should be younger if you have a long history of obesity. But what was I going to say here? There's a really great study where they sampled the endometrium of consecutive patients undergoing bariatric surgery, and 14% had an endometrial abnormality that was in the realm of endometrial cancer. They had 4 occult cancers and 6 patients with atypical endometrium. And then in the women that didn't have atypia on microscopy, they still had a hyperproliferative endometrium. So I think endometrial cancer is definitely one where if you're taking care of obese patients out in the community, they need to be screened for endometrial cancer and asked about abnormal bleeding and things like that.
This is a different question, but that just made me wonder if those are maybe our older PCOS patients or something that have some of that endometrial and metabolic disease and all of that. But my question for you is, my name's Maren, I'm a nurse practitioner, RD in Salt Lake City, and I typically also see like bariatric gone bad, but obviously many patients benefit. But when I've seen a few of the cases, even in this last year with COVID, which has been interesting, is they come in with just profound lower extremity weakness, and basically can't walk, and their thiamine and their copper, their B12 are all kind of low. And one was a sleeve, one was a Roux-en-Y. Usually my duodenal switches are the most concerning, but I'm wondering what you recommend or what what you guys do as far as monitoring vitamins versus just telling them to take some, because like they say they're taking them, but I don't, levels are kind of tough.
Yeah, no, I think what you're pointing out is probably something that's way more common than we would hope for, because when a patient's feeling good and they've lost weight, they stop coming to see us. So the follow-up in the United States, it's nowhere near what it is in these other health systems. We recommend annual lab work, annual visit with the bariatric team, and and taking vitamins every day, obviously, and there's a list that the patients go home with. But I agree with you that especially if a patient has Medi-tourism, they don't get a program before surgery. So a lot of patients are going to Mexico to get these surgeries. They don't have any pre-work. They get the surgery, they get sent home, they have no education. So it's important that people are established in a bariatric program and that they're encouraged to follow. And the other thing that we're doing is trying to educate PCPs in the state about what to look for and what to follow and who needs to see us. Like,
Very nice paper published by Monday and Ryan and myself about what we see in bariatric surgery, deficiencies seen in bariatric surgery post-op, and talks about how to treat that. It's published about 2017, wasn't it? Yeah, about 5 years ago, 4 years ago. I don't know how good it was, but I thought it was good. So.
Hopefully the good outcomes outnumber the bad outcomes, but the bad ones definitely stick with you. So.